Hello everyone, this is Aritra and today I'm going to take you through a study on incidence of severe and moderately acute malnutrition among under 5 children in Bihar. This study was conducted by the Concurrent Monitoring, Learning and Evaluation Unit of the Bihar Technical Support Program. This was carried out in 10 districts of Bihar, and one district each was selected from the 10 programmatic region as defined by the Bihar Technical Support Program. Now, in each of the selected districts, 3 villages were selected based on their accessibility to the district headquarters. These categories were easy to reach, moderately easy to reach, and hard to reach. Now, in each of the selected villages, a census was undertaken to identify all under 5 children who were then followed up monthly, and the data on socio-demographic and maternal characteristics were collected at the time of enrollment. Regarding anthropometric measurement, weight was captured once every month, while the height was captured once in a quarter, and using the Sika instruments that you can see on the right-hand side. And regarding the analysis, some imputations were made to account for the missing weight and height values. However, if a child had more than 2 consecutive missing values, then their values were not imputed. And we use standard WHO dataset for calculating the z-score. Now coming to the results, as you can see in the top half of the slide, incidence of SAM is actually the highest among under 6 children, and as the age progressed, the incidence gradually came down. However, for MAM, it was slightly different as the incidence of MAM increased up to 18 months or even 24 months of age and then declined. Coming to gender differentials, surprisingly, the males were found to be more vulnerable, which actually corroborates published literature. However, it was still kind of surprising given the gender discrimination for female child that we get to see in northern Indian states. And we'll discuss this further at the conclusion of this presentation. Duration of acute malnutrition episodes, and the median duration of SAM was found to be 1 month or less, while duration of any malnutrition was 2 months. And as you can see on the right hand side of this slide, the distribution of duration shows that more than 60% of the episodes lasted for a month or less. Now coming to transition, that is like we wanted to see what happens to the SAM and other acutely malnourished children in the month after they had their onset. And there we found that slightly more than a third of the SAM cases persisted with SAM, whereas another one third improved from SAM to MAM, and slightly less than one third improved straight away from SAM to normal. However, for MAM, almost two-thirds of the children directly improved from MAM to normal. Now we collected this study's data for an year, therefore we could analyze the seasonal variation in incidence of SAM. And as has been reported in earlier literature, we also found that the incidence is actually the highest during the summer months. And remember, summer in Bihar includes monsoon months as well, and then slowly came down in the temperate months and was the lowest during the winter. And if we plotted the when we plotted the z-scores, width for height z-scores, there also we found that it was actually the highest during January, which is the coldest month in Bihar. Now coming to policy implications, as we saw that incidence was the highest in the earliest age, that is under 6 months, so these children need to be detected early. And as we know, there are very few functional NRCs in Bihar, and they are all in district hospitals, and the community-based management of acute malnutrition hasn't also picked up in Bihar. So we suggest leveraging the existing outreach platforms and channels to identify and follow up these acutely malnourished children. And as we discussed before, the gender differential, where we found that the male children were more vulnerable, and to a plausible explanation to this was found by the other studies that has been undertaken by Concurrent Monitoring, Learning and Evaluation Unit, and there we found that the male children were often taken better care, and by that better care, it was meant that instead of exclusive breastfeeding or getting the home available semi-solid diet for as part of complementary feeding, instead of that, they often are fed formula feeding, while the girl children, they are more likely to receive exclusive breastfeeding and also the home available complementary feeding. So probably this is one of the reasons that we found this variation or the differential, other than of course the biological differences which has been reported everywhere. And regarding the seasonal variation, we believe the high incidence of SAM in the summer months is possibly related to infectious diseases that increases during the monsoon. And to tackle that, we recommend awareness generation, identification, and early access to care during the summer and monsoon months. Thank you, and I'll be happy to take questions later on.